Hello, a very warm welcome to the cardiology session of CAPIO. I'm Dr. Shiv Kumar. I'm an intervention cardiologist, director cath lab, and chief of cardiology at Apollo Hospital, Secunderabad. My passion is in intervention cardiology. I've been doing interventions since 1994. And so far, we have done reasonably decent numbers, roughly about 17 to 18,000 angioplasties have performed so far, and more than 40,000 diagnostics. Off late, I started working in a new dimension, that is artificial intelligence. And we partnered with Microsoft, and we developed the first ever artificial intelligence based cardiovascular disease risk score, which was a global score, and it had a stupendous success. A lot of universities all across the globe have accepted, recognized, and it will be published in several journals very soon. Similarly, our center is the first center in this part of the country which has set up a heart command center. And we work on the latest technologies and the advancements in cardiology using that as a heart command center. And roughly about 2,000 ECGs every month we report, and we guide them, we guide the treatment, and we do the primaries and all this. So it's my privilege and an honor to be the moderator for this session today. And we have some fantastic speakers and the chair, equally important, and the great chairpersons with us. So I'll take you through there are 3 sessions which are going to be there in today. The first session would be the speaker would be Dr. Sai Satish, and Dr. Surendra Reddy would be the chairperson, and followed by Dr. John George. Dr. Abhijit Seth will be the chairperson, and Dr. Satyaki from Bangalore, who will be talking on the robotic surgeries, and then Dr. Jailal would be the chairperson. And whatever the questions you have, you can please put in the chat box, and we would be answering them, of course, not immediately. You please put your mail ID and your names, and within a week, we'll reply you back through the chat box. So let's start the session, and we have an action-packed session for the next half an hour to 45 minutes. The first talk would be the transcatheter therapies, no patient left behind. And for this, I invite the chairperson, Dr. Surendra Reddy, a well-known cardiac surgeon from US. He's the director for Springfield Hospital at Ohio, USA. He's been nominated by Consumer Research Council as one of America's top surgeons continuously for the last 10 years. And I'm happy to share that Dr. Surendra Reddy is the country convener of GAPIO from USA. Dr. Surendra Reddy, please.
Dr. Shiv Kumar, thank you very much for that kind introduction. Let me also thank GAPIO for giving me the honor and privilege of being one of the chairpersons for this important cardiovascular sciences session. Having been a cardiovascular surgeon for 4 decades, let me also say that I am very engaged now in prevention of cardiovascular disease. I believe it is our responsibility as well as opportunity to engage in prevention first. More specifically, I'm engaged in prevention of hypertension, which we should look at as a preventable disease. With that, let me introduce the very first speaker, Dr. Sai Satish. So Dr. Satish is a well-known cardiovascular interventionalist from Apollo, Chennai. He has an extensive training background, including recently training in transcatheter valve replacements from Netherlands. Prior to that, he trained at Cleveland Clinic performing complex cardiovascular interventions. including left main coronary artery disease, multivessel disease, chronic total occlusions, etc., which are all very difficult interventions. He has also been a proctor for rotablation and transcatheter valve implantations, and he is on several advisory boards. He has performed many live demonstrations, and he is on the investigational teams of several important studies that are underway. Examples would be Spirit 5, Absorb Extend, BioMime 1 Indian Registry, etc. And with that, it's my pleasure to again introduce Dr. Sai Satish for the very first talk of the session on state-of-the-art of cardiovascular interventions. Dr. Satish, you may proceed with your presentation.
Hello, everyone. First of all, I'd like to begin by thanking the organizers of CAPIO for having me here with you. And of course, I would like to thank Dr. Shiv Kumar, our moderator, and Dr. Surendra for chairing this session. Since I have a small time constraint of 8 minutes, I'd like to jump right into the presentation. The topic I have today is transcatheter therapies, no patient left behind. So this is a beautiful article which gives us a perspective of Indian data on the incidence of aortic stenosis. And what we have learned from this article is 1 in 8 people over the age of 75 are likely to be affected by this condition, and more than 1 million cases of aortic stenosis are diagnosed in India every year alone. What is TAVI? Transcatheter aortic valve implantation is a procedure that allows us to replace a patient's aortic valve non-surgically, that is completely percutaneously. Now, this procedure has taken so much hold of the aortic valve replacement arena in the last 10 to 15 years that literally no patient is off limit. Like, for instance, this 91-year-old man came unconscious, cardiac arrest, CPR, severe aortic stenosis, surgical turn down, deteriorating kidney function, gastric bleed. There's no one on earth who would have touched him before therapy like this was available. And he did so beautifully. This was him 1 year later giving a talk in Singapore on the second lease in life.
How did you do this wonder?
I'm so happy that you're all right. You're happy? You're feeling better?
Of course I'm happy, but yeah.
So the lady I just showed you was just 36 kilograms. She was unfit for any form of surgery, and yet that is her speaking just minutes after the TAVI procedure. Now, take this lady, for instance. She was 5'2" tall and 137 kilos, and she had an aortic valve replacement, was home on day 2. Now, a lot of patients of aortic stenosis who are miserably ill have benefited from TAVI, but this patient is rather unique. So I thought I'd take a little time to talk about him. A 64-year-old asthmatic, severe heart failure for over 10 years, who was gradually worsening. He had pure aortic regurgitation, basically meaning there's no calcium for the valve to stay in place at all. And luckily for him, he came to hospital with shortness of breath and had a cardiac arrest in the ER when I was in the cath lab. The anesthetist was unable to ventilate his lungs. He was too wet. He was crashing. His heart function was hardly 15%. And you can see from this echo how the heart is barely moving and how large it is, almost 9 centimeters. You know, normal heart is not supposed to be more than 5.5 centimeters. So it's almost twice the size of a normal heart. And while he was rushed into my lab, he had a cardiac arrest. And you can see on CPR, the entire TAVI procedure was performed. Every time we gave cardiac massage for a couple of minutes and then worked for 30 to 40 seconds and gave cardiac massage for another couple of minutes. And you can see in the center image how we're working on a completely still heart.
I pray God for your long life. Hemant, I'm so happy to see you like this. I pray God.
हैप्पी दिवाली टू एवरीबॉडी। मैं घर आ गया हूँ, मेरा तबीयत बिल्कुल ठीक है, अभी धीरे धीरे इम्प्रूवमेंट हो रहा है।
So you can see in this case that he came to hospital, had a cardiac arrest on a standing still heart. We actually replaced his aortic valve. He woke up on day 2, went home on day 5, and continued to get better. Moving on to the next topic, mitral clip. Cardiovascular disease is the leading cause of death in the world today. increasing life expectancy, skyrocketing incidence of hypertension, obesity, diabetes, all contribute to a staggering incidence of heart failure patients in India alone. These heart failure patients have a miserable quality of life. 30% of them die in hospital, and over half of them are readmitted to hospitals within 6 months. Mitral regurgitation is a significant component worsening outcomes in these patients. It worsens their quality of life. Now, we have spoken about aortic valve disease. Data shows that mitral valve disease is almost 3 times more prevalent than aortic valve disease. And there's a huge unmet clinical need. If you look at the number of aortic stenosis patients that are treated in America, about 14%. And only 1.5% of mitral regurgitation cases are treated. And if this is in America, it's safe to assume that India will have at least that many cases considering our population. Now, what is the mitral clip? It's a mechanical solution to a mechanical problem. We all know that the mitral valve is the valve between the left upper chamber and the lower chamber of the heart. It's the first valve that blood encounters as it enters the heart. And when this valve is incompetent and leaky, blood flows backward into the left atrium, making the patients quite sick, choking up the heart. Now, I don't have enough time to talk about data, but there's been enough data from 2003 that this therapy was induced to show how beneficial it is to patients. I'm going to jump right into a case and then explain about this a little bit more. So this was a patient who was 86 years old, who was very active, doing well until 9th March 2017, when she presented with sudden severe shortness of breath. She was rushed to hospital. She had actually ruptured one of the chordae supporting the mitral valve, producing severe acute MR. Ever since then, her quality of life was miserable. She had 6 hospitalizations for heart failure and a drastic reduction in quality of life. She could hardly walk 50 meters before having to sit down. So you can see in these images how it's just a small, simple clip that in real time with 3D echocardiography and fluoroscopy, we actually cross the mitral valve, grasp both the floppy leaflets together and leave the clip there, bringing the leaflets together, abolishing the leak. So this was her on day 1, this was her on day 2, and this was her at discharge. She went on national television just a couple of weeks after her procedure to talk about her incredible improvement in quality of life. She played badminton with people her age and her grandchildren and showed how fit she can be in spite of being that ill over the last 6 months. So this is an 81-year-old man who was bedridden for severe heart failure for 1 year. He had actually forgotten how to walk. Now, one of his children was in New Zealand, the other one was in America, and they had given up on him. He was bedridden for a year. Every month he would rush to hospital. He would be rushed to hospital, had to have injections to remove the extra fluid from his lungs and his body, and then come back, and that was his quality of life. And when I said that, look, I think I can help him, there's nothing else wrong with him, there were several questions thrown to me as to what I was trying to prove, because here's a bedridden man, and what more could I do to improve his quality of life? He's 81 years old, and he has, at an average, has 2 hospitalizations per month. And you can't even think of operating on somebody like this.
So in 2016, when my dad had a heart attack, he was obviously put on certain medications, and we were using those medications for a while. And after about an year, his ability to walk was decreasing. His physical ability to just sit and concentrate or do his own things was getting limited. More so in the last 8 to 10 months, when he was not able to go use the restroom on his own, is when things started really going south. He started having pulmonary edema, which would make his legs swell, and the liquid in the lungs was making him breathless. So I think MitraClip was really a magic for us. And this whole process and the procedure was a miracle. And We are really hopeful that with the combination of reduction of the medication and physiotherapy can he can regain some of his mobility back and enjoy his life. Maybe take short walks outside and just feel the wind in his face.
So every time I'm confronted with a patient like this, patients that have given up all hope, it's when I think I'm so blessed to go into work day after day and do what I do. So all the daughter wanted was for her father to feel the wind on his face and walk in the lawn. And we went ahead, we did the procedure, and these are some screen grabs explaining what happened. So 1 month later, I get a message from the US saying that this is my father sitting and watching television, and he hasn't had a hospitalization that month.
Last.
So all she wanted was to see him walk in the lawn and look at the transformation. 6 months later, not a single hospitalization, heart function bounced back. He had to relearn how to walk. He had to improve the strength in his legs again, but he's back to gardening, walking in his lawn, and he looks like a completely new person. So to conclude, transcatheter therapy for structural heart disease is here to stay. No patient is too old or too sick for a transcatheter procedure. The sickest show the most gratifying recovery. And as more and more doctors get trained in performing these procedures, more patients will be treated and the cost will come down. Thank you so much for the patient listening. And I'm really sorry if I exceeded a minute or two. Thank you all so much.
Thank you so much, Dr. Sai Satish. It was a wonderful talk. And we will discuss at the end of the session. And I thank Dr. Surinder Reddy for his valuable comments. Thank you. So moving on, the second session is equally interesting, and it's basically the robotic coronary interventions during COVID era. I take pleasure in inviting our chairperson, Dr. Abhijit Seth, to this session. Dr. Abhijit Seth is again a very renowned cardiac surgeon trained in the United Kingdom. He is the president for the National Board of Examinations, which conducts the postgraduate courses in 84 disciplines all across the specialties. He is also the governing board member of NABH and is a co-chair of UNESCO. He is currently working as a director of medical services at Apollo Hospitals, Ahmedabad. He has published more than 20 peer-reviewed journals. Dr. Abhijit Seth, please.
Namaste. Thank you very much, Dr. Shiv Kumar, for giving kind introduction of mine. I also extend my gratitude to Gapio to give me an opportunity to share the talk during the session of cardiac sciences. I am pleased to introduce the speaker of the session, Dr. John George. Dr. John George is a clinical professor of medicine at Sydney Kimmel Medical College at Philadelphia. Dr. John is also the director of cardiac catheterization laboratory at Einstein Healthcare Network and clinical professor of medicine at Sydney Kimmel Medical College at Philadelphia. Dr. John is former research instructor at Temple University Health System. Dr. John has done his Master of Business Administration from Fox School of Business and Management from Temple University. Now I will request Dr. John George to give his talk.
Greetings. I'm John George from Philadelphia, Pennsylvania, United States. First of all, I would like to thank Dr. Abhijat Seth for the kind introduction. And second, thanks to the organizers and the planning committee members for this prestigious meeting, the Global Association of Physicians of Indian Origin, and for inviting me to give this presentation. I'm honored to be here. Today's topic is robotic coronary interventions during the COVID era. Very apt for what's going on throughout the world today. Here are my disclosures. So as you know, interventional cardiology procedures have not changed much in 40 plus years. The procedure was initially done with balloon angioplasty by Dr. Andreas Grunzik back in 1977, standing at the patient's bedside, wearing a lead apron and a gown and a cap and a mask. And today, in 2020 and beyond, we still do procedures the same way. Even though we've had substantial advancement of technology with fluoroscopy and with stents and all the adjunctive devices, procedures are done pretty much the same with the same risk to the operator of radiation and orthopedic injury. Until, of course, CorePath and robotic-assisted intervention, which is the bulk of what I'm going to talk about today. I was honored to host Dr. Raf Bayar from Israel, who was the one who came up with the original concept of remote-controlled coronary interventions and doing procedures robotically, which he published back in 2006. And if you compare traditional versus robotic intervention, there are a multitude of advantages, including assessing anatomy with a more ergonomic visualization by looking at a big screen right in front of you as opposed to leaning over the patient's bed, navigating lesions by automated techniques, robotic techniques, as opposed to manual hand old-fashioned techniques, measuring lesions, positioning the stent and deploying the stent all robotically as opposed to the errors of manual intervention. The first publication on the feasibility of this involved 164 patients with over 95% procedural success rate and no device-related complications. Subsequent publications have also demonstrated the advantages of robotic interventions by avoiding longitudinal miss, by being precise in the deployment of stents, with a significant difference, 12.2% of geographic miss in robotic interventions versus 43% in manual. We've, as for radiation risk, we've found a variety of different ways to control the exposure of the operator to radiation by creating all kinds of barriers, using caps and glasses and lead aprons and shields and movable skirts. We've tried to protect ourselves as an operator. However, the statistics are staggering. Interventional physicians receive more radiation dose than nuclear power plant workers per year on average, and almost or more than double. So nuclear power plant workers on average 1.23 millisieverts per year, while interventional physicians are exposed on average to 3 millisieverts per year, despite these advances. Furthermore, we know that one day in Chernobyl, which is a nuclear power plant disaster site, which is now uninhabitable, has an exposure currently of 0.003 to 0.005 millisieverts per year. That's one day in an uninhabitable zone. Today, interventional physicians are exposing themselves to 3 millisieverts. Of course, that's in the course of a year, but significantly higher. Multiple publications have been done to prove that there is significant reduction in radiation exposure for the physician. 97% in this early study looking at peripheral interventions with robotics. But if you look at the right corner of the slide, you'll see that there's also 95% reduction for staff. And the reason for that is critical. It's based on staff positioning in the room. Traditionally, you have position 1 and 2 occupied by the operator and assistant. And once you go into robotics, the assistant goes further away from the radiation source. And we know from studies that as the staff distance doubles, the exposure is decreased fourfold. So there's a dramatic decrease in radiation exposure as you step away from the source. More recently, Dr. Tejas Patel from Ahmedabad published a study that looked at his robotic experience, which is the largest in the world, and demonstrated that there's even lower patient exposure by using robotics in coronary interventions. And he's demonstrated that through multiple studies, primarily because you're able to adjust patient bed heights and distance of the patient from the radiation source dramatically, that you wouldn't be able to do comfortably if it wasn't a robotic case. So let's step into the COVID-19 era, which is the topic of today's talk. We all know that it's impacted the workflow in the cath lab dramatically, and we expected that when the pandemic hit in March of 2020. We knew that prior to that, our cath lab personal protective equipment involved just a hat and glasses and mask and a gown with gloves. But that has dramatically changed in the COVID era to wearing double masks and eye shields and respirators and double gowns and double gloves and reducing the number of people present around a COVID patient to avoid exposure. So in that atmosphere, I tweeted this back in March when we had our first COVID-19 acute MI patient on our cath table. And I said, in this era of COVID-19, would you consider robotics for coronary interventions? The advantages being maintenance of the 6-foot distance after access while instituting PPE precautions. And we had a very successful case. And that brought on more discussion about, whether we need remote PCI more than ever now with COVID-19. Remote PCI being the ability to do robotic interventions without physically being present in the room, therefore geographically distant from the patient. So if you look at staff positioning, robotics allows you to minimize staff in the room. So conventional procedure on the left shows you position 1 and position 2 for the operator and the staff. And with procedural distancing that you're able to do with robotics, operator 1 is sitting in a console that's significantly further away from the table, and the assistant can be at the foot of the table, significantly distant again from the radiation source, as well as the viral particles during a pandemic. Therefore, leveraging robotics maximizes procedural distancing, and this is a potential benefit in a post-COVID world. From a patient standpoint, it limits exposure to the healthcare workers by positioning the healthcare workers farther away. For the physician, they get to operate from further away in this interventional cockpit that can be outside the room or further away. And for the staff, you're able to work from a geographically distant position at the foot of the table as opposed to being closer to the patient, again, allowing you to be distanced. Remote PCI is feasible. This has been demonstrated both in vitro studies by Dr. Ryan Matter in this publication, where he did a tele-robotic case in an in vitro model from coast to coast of the United States. He was on the East Coast and did a procedure on the West Coast and demonstrated that it's feasible with minimal latency with our current 5G network. But it's also been proven right there in India by Dr. Tejas Patel and the Apex Heart Institute, where he performed the first inhuman tele-robotic cases from about 20 miles away and was able to successfully perform 5 coronary interventions without even being in the room of the patient using tele-robotics. So we're not far from these benefits of robotic interventions. Could robotic PCI play a protective role in pandemics? The answer is yet to be found, but the trend is suggesting that you could potentially do these cases. So we published this editorial, Do We Need Robotics for Coronary Intervention, based on our experience. And our opinion was that we do have a need more than ever now during a pandemic to perform remote procedures. So there is an emerging value of robotics as demonstrated here, and especially within the pandemic, of procedural distancing, of conserving and preserving the personal protective equipment, and soon, hopefully, with remote PCI. And with that, I would like to conclude, and I thank you all for your attention.
Thank you, Dr. John. It was really a wonderful talk. And thanks once again, Dr. Abhijit Seth, for wonderful inputs. And you have been extremely valuable opinions you have given during the talk. Thank you, both of you. Thanks a lot. So moving on to our last sessions of today's Congress is robotic heart surgery's current status. And we have with us Dr. Satyaki as the speaker. And I invite the chairperson for this session, Dr. Jailal. Dr. Jailal is a professor of surgery at Tirunelveli Medical College Hospital. He's a national president for IMA, and he's also district governor for the Women's International District Council. He's a vice president of the Commonwealth Medical Association London in UK, national coordinator for IMA, UNESCO Bioethics Chair. Dr. Jailal is a board member for Dr. MGR Medical University. So I welcome Dr. Jailal to please chair this next session.
Greetings. I am delighted, Dr. Shivakumar, for the kind words of introduction on me by him. Thanks to the Global Association of Physicians of Indian Origin for giving this opportunity to chair this session during this Global Indian Physician Congress. I am delighted to introduce Dr. Satyaki Nambala, a senior consultant and the chief of cardiac surgery at Apollo Hospital, Bangalore. Dr. Nambala has performed more than 9,000 open heart procedures and over 3,600 minimally invasive surgeries in his vast experience spanning across 15 years. Dr. Nambala is well known for his experience in minimally invasive CABG. Currently, she holds the largest series in the world on minimally invasive valve repairs and also the replacements of the valves. His robotic heart surgery experience is also the largest in India, the only successful program so far. With these words, I'm introducing to you Dr. Satyaki Nambala and inviting Dr. Satyaki Nambala to deliver a lecture.
Good afternoon. I am Dr. Satyaki Nambala, and the topic that I'm presenting today is robotic heart surgery in India and its current status. First of all, I would like to thank GAPIO for this opportunity to speak to you all. And I would like to thank my chairpersons, Dr. Surendra Reddy, Dr. Abhijit Seth, who's the president of the NBA, and Dr. Jailal, who's the president of IMA. Now, the reason I've chosen this topic for presentation is basically because I want all doctors in India to understand where robotic heart surgery is heading in India. Most of you may not have heard that robotic heart surgery is actually available in India. The truth is, it is available for the last 6 months or so now. And if you look at the trajectory of what has happened, you will see that robotic heart surgery started in the West somewhere in 2006, 2005. And since then, several stalwarts like Dr. Balki in Chicago and many others have contributed thousands of cases, heart surgical cases, that have been performed by using a robot. Now, there are several reasons why it did not take off in India. I will elaborate some of those in the subsequent slides. But I think the most important factor here was cost and lack of training, and also lack of support staff. I'll go on to my next slide and tell you what is happening in robotic heart surgery today. The most important question that comes to anybody's mind is why robotics in the first place? Now, again, if those of you who don't know, India is now in the forefront of minimally invasive cardiac surgery, where the entire operation or a heart operation, like a valve repair or a valve replacement, and including CABG, is now done through very small incisions. It's called minimally invasive cardiac surgery, or MICS in short. And some of us are pioneers in this and have contributed extensively. As far as robotics is concerned, the advantages are that you use a camera that is three-dimensional, which gives phenomenal depth of field, and it's almost like sitting inside the heart and operating. It enhances surgeon comfort. And again, for those of you who don't know, when you do minimally invasive surgery, there's a lot of discomfort for the surgeon, and that discomfort part is eliminated when you use a robot. Now, compared to minimally invasive surgery, the amount of chest wall trauma with a robot is extremely minuscule, which means that you're operating on the heart through 8mm ports. There is no rib spreading, and it's a closed chest operation. And when you do a closed chest operation, there are several other benefits as well, such as reduced blood loss, decreased pain, the likelihood of infection being almost zero, and several others. Like I said, for anybody to do robotics, minimally invasive surgical background is extremely important. And those who are very good at minimally invasive surgery can logically move on to robotics. Now, one of the biggest advantages of robotics is that, unlike minimally invasive surgery, the entire team participates in the operation. From all aspects of all kinds of people who work in the operating room can see what the surgeon is doing and do it in a highly magnified manner. This actually reduces errors, and it makes surgery much more simple and straightforward for everybody. Now, there are, of course, limitations to robotics. One of them, like I discussed earlier, is the expense involved. But when you look at the whole scenario, and when you look at the costing as a whole, including patient stay, blood transfusions, infection, the need for higher antibiotics, since all these are reduced, although it is expensive when you look at it, about $1 lakh or so more than conventional open surgery, the overall advantages actually make this not so expensive. There, of course, is a very steep learning curve. The experience in minimally invasive surgery is extremely important prerequisite, and most of us who have gone on to robotics have a very, very wide experience in minimally invasive surgery. Initial setup is definitely cumbersome. It requires a very well orchestrated team. The whole team needs to be trained with robotics. Each one going and doing training sessions at the robotic lab, and practically everybody from assistant surgeons, technicians, physician assistants, nurses, and anesthesia people are all trained for robotics to be successful. How do you choose patients? Now, obviously, when somebody starts with a robotic program, most of the patients we choose are very straightforward operations per se. That means we generally don't want to choose patients with a very complex anatomy, with a very complex procedure or technique. We don't want to choose patients who have a very small chest cavity or a very large heart. We also don't want to choose patients with external deformities, such as crowded ribs, pleural adhesions, whatever, pectus. These kind of patients are not the patients we choose for robotics. Generally, the ideal patient is a large, well-built patient, preferably a male, who, even if it is obese, it's all right, but there should be a good AP and transverse diameter. That means you don't want a patient who has a very small chest and a protuberant abdomen. But a big-chested man, even if it is, patients who have emphysematous chests are also suitable for these kind of operations. Generally, the procedures or techniques should be straightforward and simple to perform. And even in the case of reduced procedures, they can be considered as ideal. Most of my presentation is going to constitute of videos, and these videos are going to be very simple videos demonstrating, and I'm going to take the liberty to run these videos faster since there is paucity of time. As you can see, these are small 8mm ports, and you can see that robot moving, and there is a surgeon who sits next to the bedside who's looking at the monitor, and there's another surgeon who sits at the console who controls the robot while the surgery is being done. Now, in general, if you are doing a valve replacement or a repair, a small incision is made, generally about 1 inch or so, through which the ring that is used for repair or the valve that is used for replacement is introduced. And you can see me sitting there on the console and controlling the robot with my hands. It's almost like driving a car. And of course, the movements are highly precise and very well controlled. Often at times, much better than what I would do with open surgery. I'm going to go on to the next video. You can see that there are several monitors in the operating room, which everybody can look at and understand what's happening inside the chest. Now, this basically shows how a myxoma is removed robotically I will go on to the subsequent slides and tell you what are the kind of operations that can be done robotically. And you can see that a large tumor is removed with the robot. And what you will see, like I said, I'm going to run this. That's a pretty large myxoma removed from the left atrium. And when you hear this patient, you will see that the incisions are extremely small. The patient is just 1 day post-surgery. And he's actually saying that, there's practically no pain. And you can see that these incisions are extremely small, just, about an inch or so. And the port sites are just 8 millimeters, which are dressed with small band-aids. This is a robotic mitral valve repair done at my center. And again, like I said, this is a PML prolapse. You can see the torn chordae. This is a P2 prolapse. That's the P2 scallop, which is excised. And you will see that we simply bring the edges together, sew it back, put a ring, support this repair. And when this is done, you will see there's practically no leak at the end of this operation. Like I said, I'm going to move this a little faster, just so that, time is saved. That is a ring that has been placed there. And if you look at this valve, there's a little small leak at the center. But as we inflate that ventricle further, you will see that practically there is no leak at all. And this patient had a severe MR prior to the surgery. So what is our experience? If you look at this entire country's experience, there are practically 3 centers doing these procedures. Now, 2 of these centers, one in Delhi and one in Chennai, generally uses the robot to harvest the internal mammary artery for a robotically assisted minimally invasive CABG. Now, our center in Bangalore is the only center that does the entire spectrum. Still, our experience is extremely small, just about 4950 procedures so far. And you can compare that. We have completed more than 3,500 minimally invasive procedures, and we're just 50 robotic procedures now. But what everybody needs to understand that is that although it is only 50, it is simply an extension of minimally invasive surgery. So the safety, the efficacy, the accuracy of the operation, and the durability of the operation is not affected by using a robot. What are the procedures that we can do? We can do ASD closures. We can do PAPVC rerouting. We can do removal of left atrial myxomas. We can harvest both mammaries using a robot. We can repair a mitral valve. We can replace a mitral valve with or without a tricuspid valve repair. These are the only procedures that are currently possible. An entire CABG as of now is not possible to be done robotically. And like I said, we are the only center to do the entire spectrum, and our outcomes have been fantastic. And I think this is what is going to be the future of heart surgery, not just in India, in the entire globe. Overall, if you look at it, almost about 10,000 robotic surgeries have been performed across the globe. The safety, efficacy, and outcomes have been fantastic and comparable to open surgery, and in many cases, and in many situations, even better than open surgery. So these are just illustrative photographs to show you how it looks after the wounds have healed. The one on the left shows you the patient where the myxoma was removed through that little small incision, and you can see those port sites as well. The one on the right shows you a patient in whom a mitral valve repair was done, and you can see that again, this is practically immediately after the operation. So the wounds are still raw and fresh, and you can see that these are extremely small. With this, I end this presentation. Thank you very much for patient hearing.
Fantastic presentation, Dr. Satyaki. It was really nice, heartening to see that. And Dr. Jailal, many, many thanks to you for chairing this session. And thank you, both of you. Thanks once again. So I thank all the 3 speakers for their wonderful and excellent presentation. All the 3 presentations were superb. To start with Dr. Sai Satish, I think he has done a wonderful job, and he, of course, he's doing a wonderful practice every day, and probably he's one of the best numbers in TAVI in the country today. And as he said rightly, that TAVI is the one procedure which can transform and which can give a hope to all those patients who lost hope in the last several decades. You have seen the cases which have been shown by him. Wonderful, really, that basically the 75 years aged man, 81 years man, the person who could not get out of the bed is walking, playing. That's the power of TAVI is. So I feel we all get motivated. As an intervention cardiologist, I can say that TAVI is going to be a structural heart disease management would be the mainstay in the next decade. So thank you once again, Dr. Sai Satish. Moving on, Dr. John George, a close friend of mine. I'm so happy that he covered about the robotic interventions. And in fact, very soon, that will be coming into, in addition to the Tejas Patel, probably the other centers are also going to pitch in for this robotic cardiovascular interventions. And one of the biggest advantages of robotic interventions, as displayed by him, is, as told by him, is that we can do a remote control plasties. So imagine a situation that you have a patient, a cath lab, which is about 700 miles away or some very far off places where probably you may not get that expertise, but you have a cath lab and other things. If you have a robotic arm, you can perform an angioplasty. So even far-flung areas where there is a basic cath lab is there with an arm, probably we can perform the complex procedure by any expert in sitting in his central console room. So I feel that in next decade, again, robotic interventions would be probably the mainstay of procedures in metros as well as in the smaller cities. At the last is nothing to compare about Dr. Satyaki's presentation. I think he's one of the wonderful surgeons, very experienced surgeons on minimally invasive surgeries. And he narrated very nicely that how a minimally invasive surgeon can transform himself into a robotic surgeries, and probably with less of a trauma, because today bypass surgery, one of the biggest drawbacks is probably the sternotomy, and the sternotomy causes a lot of discomfort to the patient and other things, and majority of patients are scared of that. So probably you can completely avoid and do this minimally invasive surgery through robotic means and achieve one of the greatest results. So again, probably today we covered the areas, what is the future of cardiac sciences in the next 5 to 10 years, and we are all geared up and we are looking forward for this. Thank you so much. Thank you for your all attention. I know there have been a lot of questions. I could see the chat box full of questions. However, lack of time, I really can't answer them, all of them, but I assure you that please leave your email IDs. We'll get back to you within a week through a chat box. Thank you so much. Thank you, everybody.